Doctor, could you please state your full name for the record?
Michael Olushoga.
And could you please spell your last name for the court reporter?
Olushoga.
And where are you currently employed?
At Vanderbilt University Medical Center.
And how long have you been employed there?
I started my employment August of 2022.
What is your position at Vanderbilt University Medical Center?
I am an assistant professor in clinical emergency medicine.
And what do your duties include as an assistant professor of emergency, did you say medicine?
Yes, ma'am, emergency medicine. So, again, I staff the emergency department, and also we're responsible for clinical teaching of residents and medical students.
And as part of those duties, are you a doctor that treats patients that arrive in Vanderbilt's emergency department?
Yes, ma'am.
And I guess, how long have you been in that position?
So I graduated residency in June of 2021, I've been practicing as a board-certified emergency medicine provider since then. But I did a residency at the University of Alabama in Birmingham, so I got my MD in 2018.
And what is your educational background before you became an MD?
I have my Bachelor's of Science in Biology from Rhodes College in Memphis, Tennessee.
And are you board certified?
Yes, ma'am.
Do you hold any other certifications?
No, just in emergency medicine.
Approximately how many patients would you say that you've treated in the emergency department?
I can't put an exact number on it, but on average shift, I'm seeing 2.3 patients an hour, and my average shift's around 9 to 12 hours, so I can't put an exact number on it, but it'll probably be in the thousands at this point.
At this time, I would offer Dr. Olushoga as an expert in emergency medicine.
No objection. Okay. All right, ladies and gentlemen of the jury, Dr. Olushoga will be allowed to give an expert opinion based on his training and experience that a lay witness wouldn't be allowed to give. You can place such weight upon his testimony as you choose to. Okay?
Dr. Olushoga, could you please describe when you're working in the emergency department and a patient comes in, how does it get assigned to a doctor to treat that patient?
It depends on bed availability mostly, especially if every emergency department is different, but in our emergency department, if you're very critical and need a bed, whatever's available and what's open is what you're given, essentially.
And is it just, are you the only person there, or is there a treatment team that's in place?
At Vanderbilt, we have different teams. So we have a total of 4. There's Team Nash, Team Parton, Team Lawson, and Team Lewis. And 2 teams are on the A pod and B pod. The A pod, which is the pod I was working, it was Nash and Lewis. Yeah, and the B pod is the other one, Parton and Lawson.
And were you working in your position on February 25th of 2023?
Yes, I was in the Nash team on overnight shift.
And did you treat a specific patient, Miss Jade Benning?
Yes.
And in preparation for testifying in this trial, have you reviewed her medical records?
Yes.
Your Honor, at this time, I would ask that the witness be handed 2 large binders.
Okay.
Dr. Olushoga, have you been able to review the records that are in the 2 binders that were just handed to you?
Yes.
And did you verify that those are the medical records of Jade Benning from Vanderbilt University Medical Center And her admission that began the night of February 25th, 2023 until March 6th of 2023.
Yes.
And is it approximately 1,331 pages of medical records?
Yes, I'm seeing 1,327, but yes.
1,327.
Yes, ma'am.
Your Honor, at this time I would ask that the 2 binders of medical records be made the next numbered exhibit, but I would ask that this witness be allowed to retain the exhibit for reference during his
Okay, we'll
testimony.
mark them when we're finished, as exhibit 10.
No objection, sir.
10?
Yeah, no objection.
Okay.
Dr. Olushoga, if you need to reference a particular page of the medical record in order to answer the questions, please feel free to do so. Can you please describe Jade Tristan Benning? What was your first interaction with her? Did you see her as a patient and or did you receive information about her prior to her arrival to your emergency department?
So I did receive information prior to our arrival. We have an EMS radio that's located on the APOD, the pod I was working. And from my recollection, the EMS crew, they typically call in, especially if there's an emergency or even if they have any questions about a case. And I just remember that they said they had a young female who was in cardiac arrest, and they had tried some acute cardiovascular life-saving stuff, but weren't able to get a return of spontaneous circulation, and that they'll be here in a few minutes. So when I heard that,
I stop you right there. Can you explain what a return of spontaneous circulation is?
yeah, so that's usually abbreviated as ROSC, but that essentially is when a patient is able to have a heartbeat, essentially, or function of something, of some sort. Typically, it's a heartbeat, a pulse, a cardiac rhythm, a blood pressure, vital signs. Those are all signs of life, so a return of spontaneous circulation.
And you said that you had information that EMTs were attempting to get that ROSC back.
Yes.
Were they able to, prior to Ms. Benning entering your emergency department?
Not from my initial assessment of the patient. She was still clinically dead upon arrival to the ER.
And I'm sorry, did you say she was clinically dead?
Yeah, like from my clinical assessment, there were no signs of life upon her arrival to the emergency department.
And when she arrived, can you describe kind of what was she on?
From what I remember, she went to one of our resuscitation bays, T4. She was still on the EMS stretcher receiving CPR. She was, like from my exam, unresponsive. Pupils were fixed and dilated, no spontaneous respirations. She had a supraglottic airway in place, the eye gel, so they were breathing for her and they were doing chest compressions on her.
And can you explain kind of what does that mean when someone's pupils are fixed and dilated? Medically, what does that tell you about their condition?
It's concerning that there is significant neurologic damage. Your pupils constrict on their own. That's not something that you do purposely. So when that reflex is gone, that's a concern that there's been significant neurologic damage, and also that that person is not alive.
And can you describe, I guess, like her physical temperature?
I mean, she was cool. Her skin was cool. I mean, she was also mottled, like kind of cyanotic, which means she was kind of blue, which are all signs of hypoxia, which means lack of oxygen. But all clinical signs pointing that she was dead upon arrival to the ER.
Did you have any information as to whether or not Ms. Benning was pregnant or not pregnant?
So that information did come across the radio as well, that she was pregnant, but they did not know how many weeks she was.
So they knew she was pregnant, but they didn't know how far along?
Yes.
Okay. Could you tell just by looking at her that she was pregnant?
I could tell only by palpating her stomach that she had. Essentially, you could feel the fundus of her uterus, which is the top of her uterus. And why that's important is it has to be above the umbilicus, which is her belly button, which tells me that she's roughly greater than 20 weeks. It's not an accurate measurement, but that's what we're taught in medical school.
And kind of going back to, you said that her pupils were fixed and dilated, and that was indicative of significant neurological damage. Do you have a full assessment of her neurological capabilities at that point on admission, or is that something that you learn more about as you're treating?
You learn more about as you're treating, because essentially when somebody comes in and dead, you do a quick assessment, because the priority is maintaining perfusion, which is chest compressions, making sure that blood's going to the brain, vital organs, and in this case, the fetus, as you continue to resuscitate.
And your assessment of the fetus at that kind of initial stage, what's being done at that point when she first presents to the ER?
So other than just confirming that she was pregnant, not much. When we did know that she possibly could be pregnant, I did call what we call OBET call. We have a OB response team at Vanderbilt, and they were at the bedside in the event that we were able to achieve ROSC. They could also intervene.
And what treatment did you provide to Ms. Benning?
So after she arrived to the emergency department, we continued high quality chest compressions. She was transitioned from the EMS stretcher to our ER stretcher. Chest compressions were continued. Medications were ordered per our ACLS, which is Advanced Cardiovascular Life Support Protocol. And we were able to achieve ROSC, which return to spontaneous circulation, shadow pulse. She was then intubated, and after intubation, we essentially got the OB team to evaluate her fetus as we were getting better access. That means better IVs and blood pressure monitoring. And then we then went to CT scan because we were able to get a pulse back, and we were able to admit it to the ICU.
Can you describe, you said that Ms. Benning was intubated. Can you describe what does that mean to intubate a patient?
So when you intubate a patient, essentially you're protecting their airway, meaning you're breathing for them. You're putting the patient on a ventilator. The reason you would do that is because the patient's not breathing for themselves. So essentially you are creating a definitive airway so that oxygen can be delivered and carbon dioxide can be exchanged for the patient.
And can you describe typically when you intubate a patient, I guess, what's the process of how that procedure is done?
Typically, when you intubate a patient who is alive and breathing, you usually administer medications to assist with the intubation. Medications that can either basically help them become more comfortable, so that you can pass this tube, because intubation is passing a pretty large tube in their airway in order to facilitate gas exchange on the vent and oxygen delivery. That's the typical process for an intubation.
And did you administer medications when you intubated Ms. Benning?
No, I did not.
And why is that?
Again, from her neurologic exam, she appeared to be basically neurologically devastated. She didn't need anything because she had no cough, no gag. So essentially, she's not really. The likelihood of her feeling any pain or discomfort is very low. So she was intubated without any medicines.
Did you think that you would achieve a ROSC on Ms. Benning?
Honestly, no. I was very shocked that we were able to get ROSC on this patient.
And once you were able to have that return of spontaneous circulation with Miss Benning, and she had a heart rate, were you able to see what the baby's heart rate?
Yes, but it was that was done by our OB colleagues, which were already at the bedside. They did a ultrasound and were able to give me a estimated gestational age. But one of their concerns was that the fetus, the heart rate was very low, which is called bradycardia, which is very concerning, and essentially the likelihood of this fetus, continuing to develop was very low. So after I got that clinical information, that then gave me basically allowed me to say, hey, let's get some more CT scans. Typically we avoid imaging in pregnant patients because it can affect the development of a fetus. But knowing that this fetus, the likelihood of this, being what we call viable, we were able to get more information, more scans on the patient.
And the treatment involving Miss Benning, at any point did you talk to anyone that had any additional information to explain why she came to the emergency room in the condition that she did?
I do remember that during, this process of resuscitation, our social worker was able to reach out to family members that showed up to the emergency department. I do remember who I spoke to specifically, but there was some mention of possible poisoning by a family member, and that was mentioned, and I do remember that.
And is that something that was mentioned directly to you, or was it provided to you by a social worker or someone else in the hospital?
It was mentioned to me, from what I can recall. But again, the events of that night were, but I do remember hearing it specifically from a family member.
And what, if anything, did you do based off of that information?
Again, I reviewed the records. It looks like we had already, labs are already ordered by the resident. I did go back and add some other things, but it looks like the urine drug screen was already ordered, so I didn't have to add that, but I might have added another blood gas. But yeah.
And Dr. Olushoga, you said that a urine drug screen was ordered.
Mm-hmm.
If you turn to page 66 of the medical record, were there other specimens that were collected? Specifically, was any of her blood collected?
Page 66. I do see, there's like a blood gas.
And I think it might actually be 65 and 66,
Yeah.
but it goes into both pages.
Yes. Yes, there's actually a slew of labs that were ordered, yes.
And what was the collection time for that blood sample?
2230 and 2231 is what I'm seeing here.
And so there's a 2231 blood, is that correct?
Yes.
I think it was, I just order placed at 2230 and then the collection time is 2231.
Yes.
And was there also urine that was collected?
Yes.
And is that documented with its specific time?
Yes, the urine was collected at 2258.
Is that the order and then it's 2259 for the
Yes.
specimen collection?
Yeah, and the specimen was collected at 2259.
And would that be the urine that initial drug screen was run on?
I believe so, yes.
And can you describe, what do you know about that initial drug screen in the ER? Is it testing for anything and everything, or what type of testing is that?
So the urine drug screen that we typically get in the ER is a finite amount of substances, but essentially it's testing for like metabolites in the urine. Yeah, so somebody might have ingested something or using sort of drugs, test for those metabolites. I have the list if you'd like it specifically, but I have the results here.
Did it come back positive?
No, it came back all negative.
Okay. And can you describe you have this woman, she's 24, almost 25 years old. She presents to your emergency department in full cardiac arrest, and you said that she's clinically dead. Is that something commonly seen?
Not in that age group, not usually young pregnant women, no.
And can you describe, based off of, you said that the baby had a low heart rate. Was it a little bit low, or was it kind of extraordinarily low?
So the normal fetal heart rate, and what we've been taught from my recollection in medical school, is usually 110 to 160. I think I remember the OB team mentioning that the heart rate was somewhere in the 30s, so it was really, really low.
And have you ever treated a patient that came in under these circumstances where it's a young woman that's pregnant, healthy, full cardiac arrest, and people are saying she's been poisoned?
Not in my career, no.
If I can have just one moment. Dr. Olushoga, did you continue to treat Ms. Jade Benning, or what was kind of the totality of the involvement in her treatment?
Once we were able to establish that she had a blood pressure, labs were rolling in, and we got CT scans. I quickly reviewed the CT scans, and we reached out to the intensive care unit immediately because, she was critically ill, and essentially we did our best to get her to the ICU as soon as possible so she can get the rest of her post-Ross care.
And would you have been the person that would treat her during the time that she was in intensive care unit?
No.
Your Honor, I'm going to ask that this witness be handed a single photograph.
Okay.
Oh, I'm sorry.
Dr. Olushoga, do you recognize what is in that image?
Yeah, it's a vial of blood used for our lab draws.
And do you recognize certain identifying pieces of information on that specific blood draw tube?
Yes.
Your Honor, at this time I would ask that that image be entered as an exhibit exhibit. 12.
I would object to it coming in through this particular witness. May I take the witness on board?
Okay. Do you have any other questions?
I do.
Okay. Go ahead with that. Just so that.
Judge, I don't have any objection to having it marked for ID,
Okay.
but I would have more questions of this witness.
All right. Go ahead. Be marked for identification.
Thank you. Dr. Olushoga, could you describe specifically, and I need the witness to have the picture back.
Your Honor, I would object to a witness testifying to something that has not been entered into evidence.
Okay. Well, he's viewed it. You have questions?
I have
He has
specific
personal
questions of the specific things on the label that he recognizes from Vanderbilt University Medical Center.
Okay. All right. He can show that. He can see.
May I take the witness on board, please, Your Honor?
Sure.
Doctor, is it Olushoga?
Yeah.
Dr. Olushoga, were you the individual who in fact collected that blood?
No, I did not collect that blood sample.
Were you the individual who labeled that blood?
No, I'm not the individual that labeled the blood.
Prior to looking at this particular photograph, had you ever seen that vial of blood before?
That specific vial of blood? No, not necessarily, no, ma'am.
And so do you have any personal knowledge whatsoever in regards to that particular vial of blood?
That particular vial of blood? No.
Again, Your Honor.
So what are you wanting to ask if he doesn't know what that vial is?
I would simply like him
Just
to
like
explain.
phone calls, common,
I would simply like for him to explain what a stat name is, because there is
okay,
information
well,
on
you do
there.
that without the photos, so go ahead.
Okay. Dr. Olushoga, you
Yeah.
viewed that photo, correct?
Yes.
Can you describe, did it look familiar to you?
Yeah, it looks familiar to me.
I would object to this witness testifying to a photo that has not been entered into evidence.
Are photos taken of blood vials?
You mean, I guess, what's the specifically? I'm not sure what
Have you
you're
ever
saying.
seen a photo like this before?
Not a photo, but I've seen blood vials.
Okay, what is your next question?
Does it contain Ms. Benning's medical record number on the vial? Do you
Yes.
recognize that?
Your Honor, I
He
object.
can, do you know her medical record number?
It's written right here on the. Yeah.
Okay. All right, let him see the photo.
And Your Honor, may I have a ruling in regards to my objection?
He can look at the photo and see if that's the same medical record. Is that what you're asking?
Yes, Your Honor.
May I have a ruling to that, Your Honor?
I said he can do that.
Is that overruled?
Go ahead, General Norman.
Thank you, Your Honor. Do you recognize Ms. Benning's medical record number from the medical records you have in front of you? Is it also printed on that vial of blood?
Yes.
And you just testified to a collection time of 2/25/23 at 22:31. Do you also recognize that very specific date and time?
Yes.
Your Honor, I object again to that line of questioning.
Are you going to call a witness that lets us know who collected this?
It's in the medical records who collected it, but
Are you going to call another witness about this photo?
I am. I'm going to
Okay.
call Dr. Carney.
Okay.
May I have a ruling, Your Honor?
What's your question that you want to ask of the witness?
Dr. Olushoga, there is a stat name on that label. Do you recognize that?
Yes.
Objection, Your Honor.
Have a seat.
May I have a ruling, sir?
Have a seat. Go ahead.
Can you explain what that means?
Yeah, stat names are basically John Doe or Jane Doe names we give patients who are arriving to the emergency department. It allowed, because in a medical center, errors happen, and the way we prevent those errors is allowing the same system to happen every single time. So we arrive patients under the stat name so that we can place orders. Because nothing gets done in the hospital without orders being put in by a provider or by anybody taking care of the patient.
Did you give Ms. Benning a stat name?
I'm not responsible for giving the stat names, but our flow nurse gives the stat names.
So what's your next question?
Dr. Olushoga, do you know whether or not Ms. Benning was given a stat name during her ED visit?
Yeah, and it's in my note as well. If you can look at page 56, when patients are given a stat name, their whole chart reads their stat name until they're matched.
What stat name was she given?
Stat February, Mayonet, VUH.
It was what?
Stat-
I didn't hear what you said. You'll speak up.
Mayonet, VUH, Stat February.
Mayonet. What was the rest of it?
Stat February.
Okay. Any other questions?
Just a couple, Your Honor. Are all of the specimen collections from Ms. Benning, are they documented in the medical record?
Yes, from what I reviewed, they're all documented in the medical record.
Thank you. And can you turn to page 562 of the medical record? I believe it's in binder number 1.
I'm there.
And do you see that there is an entry for fentanyl on 2/25/23 at 23:27?
Yes.
And are you aware whether or not that fentanyl was administered to Ms. Benning?
Looks like it was not administered. I was aware that it was wasted by the provider.
And so that was not given to her, correct?
It was not given to her.
Can you turn to page 727, which is in binder number 2?
I'm there.
And there is an entry related to fentanyl, and it indicates a date and time of 2/26/23 at 0041.
Yes.
Is that when Ms. Benning was first dispensed and also administered fentanyl?
Yes, according to the medical record, yes.
Thank you, Dr. Olushoga. I don't have any other questions.
I have a moment. Good morning, Dr. Olushoga. I didn't introduce myself before, but I am Letitia Quinones-Hollins, and I just have very few questions for you. I want to first draw your attention in regards to what you stated as it relates to the fentanyl, so that we're clear. I think you testified that it was not first administered in the hospital until when?
I testified that, according to the medical record, she did not receive fentanyl in the emergency department until February 26, 2023, at 0041. That's when it was ordered, it looks like.
That's when it was ordered?
Yeah, and it was started at February 26, 23rd, 0045.
Was that ordered by you?
It was not ordered by me. It was ordered by it looks like a provider, Paul Francois.
Thank you. I want to now draw your attention to page 117. And specifically, I would like to draw your attention down to the bottom where it states recommendations. You see that?
Yes, ma'am.
And particularly, I would like to draw your attention to line 4 under recommendations. Could you read that for the jury, please?
Yes, it says recommend contacting police to conduct drug facilitated crime testing since no chain of custody testing available at UBUMC.
Do you know what that means?
Nope, I do not.
So, but you just stated that the record just says you would recommend that police to conduct drug facilitated crime testing because BUMC has no chain of custody.
This is a note by another provider, but that's what I read, yes, ma'am.
Okay. And it's a note by another provider, just like the note that you previously read in regards to the fentanyl being administered?
No, that is the MAR, that's the medical record. So that's the medicines that were given. That's different than this. This is a provider note.
Do you know who the provider is that provided that?
Yeah, it says here is Dr. Bucalari.
Do you know who Dr. Bucalari is?
I've spoken to her over the phone. She's the one of the toxicologists in Tennessee. So if you ever have a tox case, you have to talk to the Poison Control Center. So I've spoken to her over the phone regarding another patient, another case.
Does she work for VUMC?
I'm not 100% sure on that. I just know I've called her, toxicologist that I call her.
Had you called her in this particular case?
Nope.
Did you not have any reason to call her in this particular case?
Not necessarily, because I don't know what I was dealing with, you know.
So is that a no?
No, not yet. Yeah, no, I don't have any.
I would now like to draw your attention, if I may, to page 132. And you see where it states hospital course?
Yes.
And within that paragraph under hospital course, I believe it says per EMS report, she was found in PEA arrest and CPR was initiated for approximately 30 minutes prior to arrival. She received 4 rounds of epi and ROCS was achieved in Vanderbilt. And I think you just described to the jury what ROSC means, I'm sorry. And could you tell us one more time exactly what is ROSC?
Again, ROSC, return of spontaneous circulation, is when the patient gets a heartbeat or signs of life.
And so it says it still remains unclear if patient was found in PEA arrest or if she went into PEA arrest during transport. There have been discrepancies in multiple histories. Do you see that?
Yeah, I see that.
Do you know whether or not that issue was ever resolved?
No, and because again, this is after I saw her in the emergency department, so I have no bearing on what's written by the ICU.
Okay, so you can't answer that question.
I can't.
Thank you. I would now like to draw your attention to page 410.
I'm there.
Could you help explain to the jury on 410 where it says comprehensive cardiac NGS panel inconclusive?
Again, I'm not familiar with that lab. Again, this is not something I would order from the emergency department.
So you can't help us with that either?
No, ma'am. Unfortunately, I can't.
Could you tell the jury what is cardiac NGS panel?
Again, I cannot explain that. I don't order that routinely from the emergency department.
So you don't know what a cardiac NGS panel is?
I do not know what a cardiac NGS panel is.
Thank you. And then if you look down a little further, it says testing performed by, and it says 123 Cerner, VUMC Cerner Lab. But then the valid date range says 11/23 of 21 through present. That would have been about a year and a half prior to this date. Do you know why that would state a date a year and a half prior?
I do not know why that would read that way.
Okay. And is that related to some lab at VUMC?
I wouldn't be able to give you any information on that. Unfortunately, it's not something I'm familiar with.
So you don't know what VUMC Cerner Lab is?
Frankly, no, I don't.
Thank you. Now, you stated that the baby was not viable, is that right?
I stated that after a conversation with the OB provider, they deemed that this pregnancy would not be viable.
Okay. Do you know then, can I ask you or draw your attention to page 126?
I'm there.
And would you take a moment to read 120 126, starting from the first paragraph there where it says they have heard. I mean, you don't have to read it out loud. I just want to ask you a question in regards to it. I think it's unfair if I don't give you the opportunity to read it.
Thank you.
Okay.
Do you see there where the OBGYN team ultimately had to contact the ethics service?
Yes.
Have you ever in your career had to contact ethics when you are performing medical services?
Yes.
And for what purpose would that be?
Typically is when there's usually difficult end-of-life conversations that need to happen, and when there's not like a delineated, when there's like not a will or a designated power of attorney. Sometimes I would have to call ethics to help me delineate what's the right thing to do, or what's the lawful thing to do as well.
And do you see there that there were several conversations that were had in regards to life-saving measures for the fetus?
Yes.
And do you also see that there were apparently decisions made that, given the circumstances, there was an expressed desire to not get a C-section or anything of the sort to attempt to save the fetus?
Could you repeat that?
Yes. Do you see in the document and the record here that there was a decision made by the next of kin or the representative for Ms. Benning for there not to be any life-saving measures for the fetus?
Again, what I do see here and what I'm reading is that there was a decision that was made that was consistent. It says as what they will feel Jade would make for herself based on chart and documentation prior conversations. That's what I'm saying here.
And that's the reason why the decision made. But my question was, do you see that there was a decision made?
Yeah, I mean, it sees that what I do see is that there was a conversation here with the provider, with the family about a possible decision to do a C-section, and looks like they chose not to. That's what I'm saying here.
And then you see then that as a result of that, BUMC contacted clinical ethics services.
I couldn't say as a result of, but I do see in this documentation here that there was a discussion that was had with ethics. I can't say that that was because of that. I can't make that connection myself.
But you will agree with me that it's directly related in regards to this paragraph talking about the child in that decision.
Yeah, that is a possibility, yeah.
Do you know whether or not Mr. Taylor was ever consulted in regards to the decision regarding that fetus?
Again, I work in the emergency department. I was not privy to any of this care after the emergency department.
Do you see within, if you'll go back to page 125, right above consultation, you'll see that the mother's surrogate decision maker was Bridget, which is Jade's mother. Father and step-parents were present for this consultation and shared decision making. Do you see Blaise Taylor's name anywhere there for the decision making?
No, ma'am, I do not read that in this chart.
Okay, thank you. You had stated, if I could just have a minute. and I'm going to mess up the name, that's why I'm trying to find it, but perhaps you can help me. Are you familiar with the specific drug named cesarean? It is a drug that is utilized to help with intubation.
Could you spell it out for me?
SUCC.
Oh, succinylcholine. Yeah.
Thank you, succinylcholine.
Yeah.
I'm always cut because names are challenging. Do you know whether or not that was utilized in order to assist in the intubation of Ms. Benning?
No, she did not get that medicine in the year.
It is your testimony that she did not receive that medication?
To my knowledge, no.
Is it to your knowledge, or is it your testimony that she did not?
It's my testimony that she did not.
And the reason that I ask is because you had stated earlier that there was no need, I think you stated, for,
Yes, ma'am.
and the only reason, tell us why you would utilize that medication.
Again, typically patients who are alive and breathing, they usually still have reflexes because their brain stem is intact. So even if somebody's alive and breathing and unconscious, and you need to, protect their airway with an intubation, if you were to insert a blade into their mouth in order to lift up the tongue and epiglottis to look at the vocal cords to insert the tube, they'll gag, cough, there'll be vomit, and it'll obscure your airway. So typically what you do is you give an induction agent and a paralytic. Usually etomidate is an induction agent, succinylcholine is a paralytic, in order to make sure that they can tolerate the procedure. But again, she did not have any signs of life, was neurologically devastated. She had no cough, no gag, no pupillary reflex. She was intubated without any medications.
Thank you. Can I now draw your attention to State's Exhibit number 5? And the witness has State's Exhibit number 5. You have it in front of you, sir?
Yes, ma'am.
Thank you, Doctor. And Dr. Olushoga, I want to take you to the section where it says narrative on the first page.
Yes, I see it.
Do you see that?
Yes.
Then I would like for you to go down to 4 lines down.
Okay.
And specifically to start at the sentence, the patient's boyfriend. Do you see that?
Yes, ma'am.
Could you please read that sentence for the jury?
Yeah. It says the patient's boyfriend stated the patient was 4 months pregnant. No other medical information was obtainable.
Okay, you can stop there. Thank you. And do you see that this is in fact a report from NFD, Nashville Fire Department?
Yes, ma'am.
And do you see the name of the individual who authored this report?
I see
Crew member.
Andrea Agrawal. I
Okay.
think.
And so you see there where it actually states that the boyfriend, in this case who would be Mr. Taylor, actually did tell the fire department just how pregnant Miss Benning was, according to the statement you
He's
just
just
read.
read it, so he doesn't know anything else.
Thank you. And then, if you would turn the page, sir. And doctor, if you could look under where it says vitals.
Yes.
And do you see the section where it says CO2?
Yes.
What is that?
So Untitled CO2 is another, basically it's another, I wouldn't call it a vital sign, but it's an indication of the quality of your chest compressions. Basically, again, you breathe in oxygen, you breathe out carbon dioxide. So if you're doing good quality chest compressions, your end-tidal CO2 should be high because you're breathing out carbon dioxide. If you're doing terrible chest compressions, it'll be low, which means that you're not doing a good job circulating oxygen with your compression. So that's another marker of how good is your resuscitation, how good are your chest compressions. And also if you have like an airway, because if it's super high, could it be that your airway is in the stomach and is picking up gas from the stomach? So it's just a marker of how good is your resuscitation.
Meaning how good you're breathing, how good oxygen is coming in, correct?
Not how good oxygen is coming out, it's how good are and in this case, if it's used appropriately, how good are you circulating oxygen? Are you picking up that CO2 with once you're doing your bagging? Like how good is the CO2 coming off?
Okay.
Yeah.
You say the CO2 coming off of what?
Usually the end tidal is connected to the BVM, or the bag that they use in the bag the patient. So it's connected to the tube that's going into her throat. Yeah.
But these are things that are measured on Ms. Benning's. Would you agree?
That's what it appears to be from this document. Yeah.
And if you look at those numbers, specifically the numbers 69, 70, 113, 99, 100, 93, 93, 86, and 80. Those would be good quality numbers. Would you agree?
They're high, but yeah.
Okay, thank you. And then finally, I want to talk to you about someone's, specifically Ms. Benning. If she was described as having the ability to say things like, you've put something in my journal. Nye, Keontae. In other words, she's pronouncing words. Some of them labored, some of them not. If a person is able to talk, would you agree with me that they would have to be coherent?
Not necessarily, because drunk people can talk and they're not coherent sometimes.
Well, maybe I'm not saying that right. If a person is able to enunciate words, would you equate that to someone who is dead?
No, typically not.
Would you equate that to someone who is completely non-responsive?
No, if they're able to enunciate words, I would not equate that with that.
Would you equate that to someone who is able to breathe?
Actually, yeah, some people who are not able to speak are still able to breathe. Yeah.
But someone who is able to speak surely is able to breathe.
Yeah, typically, yeah.
And that's all I have for you. Thank you, Doctor.
Thank you.
Any regret?
Dr. Olushoga, I'm going to kind of start with the last thing that she talked to you about and go backwards. Can you go to page 562?
I'm there.
And Ms. Collins was asking you, or page 562, that's the page that we referenced with the 2327 on 22523 fentanyl that Nurse Alyssa Smith that was dispensed, but it was not administered.
Yes, looks like it was wasted, yes.
And can you turn to page 567?
I'm there.
And on page 567, is there an entry for the medication that Ms. Collins was asking you about?
Yeah, I see it.
And is that time the same time as when the fentanyl was not administered?
No, it says this was administered. This was ordered at 2:26:23 at 12:15 a.m. That's when it was ordered, and the fentanyl looks like it was the day before, so 2:25:23 at 11:27 p.m.
Okay, so those are two separate things, correct?
Mm-hmm.
And
The
so,
question said the medicine Ms. Hollins asked about.
yes,
Why don't we clear up what that is?
SUCCINYLCHOLA. S-I-N-E. And how do you pronounce that again?
Succinylcholine.
Thank you. And so that was administered at a much later time at 2/26/0015, correct?
Yes.
And also, if you look down to entries, there are entries for fentanyl, which coincide with when the fentanyl was actually administered to Ms. Benning. Is that correct?
Yes.
So you did not order those medications, correct?
No.
And so if they were administered after she went to the ICU, is that surprising to you?
No, it's not surprising.
And if you can go to page 125 and 126.
I'm here.
And can you look at, it begins on 125 and then the consultation. Number 2, it gives a description. Can you just read that silently to yourself?
Okay.
And you weren't involved in that neonatal consult, correct?
No, I was not.
At the top of page 126, there's a reference that multiple providers have advised the family that sustained a anoxic injury given the arrest impact on mother's neurological status, and they agree with that concern. The doctor says, I agree with that concern. And they say we do know the fetus appears to have been affected by the peri-arrest fetal heart rate in the 40s.
Yes.
And on your direct testimony, when I was asking you questions, you said that because
Yeah, I'm
fetuses.
going to object to the leading nature of the questions.
Okay, what is your question?
Can you explain what you know about the fetus's heart rate being as low as you described?
What I do know is that when you have a low heart rate, especially in a fetus, that is not that means the chance of viability of that pregnancy is low. So that means that the fetus is going to have a lot of issues and it's not going to make it.
And that note indicates that multiple providers are saying that, correct?
Okay,
I would
what
like
is
to-
your non-leading question?
And I'm going to also object to this particular doctor opining on the fetus when he stated before that he had nothing to do with
Okay, well, you
this.
can recross if you want to. What is your question?
I don't have any other questions regarding this issue, Your Honor.
Okay, go ahead.
Dr. Olushoga, can you go to page 59 of the medical record?
I'm there.
And can you describe What time did Ms. Benning arrive in your emergency department?
At 22:06.
And can you describe specifically when you intubated her?
She was intubated upon arrival, so around 22:06 as well.
And so that is what time she got to the emergency department, correct?
Yes. Usually there might be a little lag just because of nursing, charting and stuff, but that's, yes, around that time.
So 22:06, 22:07.
Yeah.
Thank you.
Any other questions?
Yes, just a few brief questions, Dr. Olushoga.
Yes, ma'am.
I want to take you back to page 126.
Okay. Mayor.
If you go down to the first paragraph, line 8, starting with "I offered,"
Yeah.
could you read that sentence to the jury, please?
Yeah.
Is this him saying
It's a record that's in evidence, Your Honor.
this? Is this him saying this?
No, it is not. Can you please read that?
It is, you made it an exhibit, so you can have him read anything you want.
I actually wasn't allowed to.
I didn't object to her
Is this
reading.
asking about an opinion that you were objecting to?
No, it's not asking about an opinion. It's asking about a position and an offer that is a record, that is an exhibit, that is in evidence that
I
I'm
get
asking
that.
you to read.
Okay.
Could you just read that sentence, please?
Okay, it says, I offered intervention in the form of delivery resuscitation with the goal of having an opportunity to evaluate peanut for potential impact, and they have felt that intubation and resuscitation could cause unnecessary suffering. They feel.
Thank you. And then you stated on direct examination that succinyl choline, did I say that right?
Yes.
Oh, okay. You stated that it wasn't given to her at all on direct examination, did you not?
Yes, for intubation. I did not give that medicine.
No, I didn't ask if you gave it. I asked, was it given? And you said no.
I said, to my knowledge, it wasn't given for my intubation.
I thought I clarified if it was to your knowledge or if it was given at all.
Do you have another question, or you want to argue?
So that was, in fact, that medication was given, wasn't it?
According to the medical record, it was given and it was prescribed by another provider. Again, I had nothing to do with that.
And again, can you tell us what succinyl choline is?
It's a paralytic.
And it is utilized for what?
It's utilized for multiple things, but in my prescription, I usually use it for intubations. But it's used for other things. Sometimes it can be used when patients are having trouble ventilating. So if you're on a ventilator and you're moving or jerking, sometimes it can be given for that, or it can even be given for like CT scan. Because if you need a CT scan, you need to be still. So sometimes they do that as well. But there are multiple reasons for the medication.
Can a person be still if a person is non-responsive and in a coma, aren't they still?
Not necessarily. You can also have like seizures, especially after a cardiac arrest when you have a neurologic injury. It's not uncommon that patients have a lot of seizures. So yeah, they can have seizures.
And so are you stating to this jury that that's why this medication was given at this time?
No, ma'am. I'm saying to the jury that succinyl has multiple uses.
Can you see there why it was given?
I do not see here why it was given specifically, no, ma'am.
So you can't say that it wasn't given for intubation?
I can say it wasn't given for intubation because I did the intubation and we did not give her any medicines for intubation.
Good.
And it's a one-time procedure. It's not something that happens again because the tube's in her throat. So it's not taken out and put it back in again.
But it is a paralytic.
Yes, succinyl is a paralytic.
Okay. And it is to help patients not to feel something.
Nope, it's to help the procedure, a procedure. Again, it's to paralyze the muscles. In the case of intubation, it can be used for that, but there are multiple uses for succinyl.
Thank you.
Thank you.
follow-up. Dr. Olushoga, can you turn to page 119?
I'm here.
Midway through the page of 119, there's a blue line that says history, and underneath that it has a reason for a consult.
Mm-hmm.
Can you explain, do you know what that reason for consult is?
It reads myoclonic jerks and anoxic burn injury. There was a reason for consult.
Can you describe what is the myoclonic jerk?
Yeah, so like myoclonic jerk is essentially like it's like, best way I can describe it is just an involuntary movement of like your extremity typically, but it can happen anywhere. You can have it in your face, you can have it, but it's an involuntary jerking motion. Yeah.
And is that one of the reasons that they might get that medication?
Yeah. Yeah, especially if the jerks are uncontrollable. Sometimes you have to paralyze the patient, unfortunately. But yeah, especially if you want to do like an EEG, which is like encephalogram, where they check for any seizure-like activity, which is very common after a cardiac arrest. They try to do further evaluation as the quality of the brain and all that stuff.
Thank you.
One last question.
One last question.
Can you tell this jury that that is why succinylcholine was given to Ms. Benning?
I cannot. I don't know why it was given.
Thank you.
Any other questions? All right, thank you. You can leave all of that there and we'll get it.
Okay.
Thank you. Thank you.
Thank you.
All right, members of the jury, we're going to break for lunch. Remember what I've said about all definitions, not discussing the case, forming any opinion about it. We'll get back here at 1:20 or so. You can step down the hall. Okay, you have a seat. Who would the next witness be?
It's going to be Lauren Weber.
Trying to anticipate things, asking this because of what's already been asked. Can either side explain to me whether the family's decision not to have a C-section is relevant?
No, Your Honor, I did not think so.
If I may, Mr. Taylor is charged with causing the death of the fetus as well. So anything that could affect the fetus's viability and or
You're going to
life.
argue to this jury that the fetus may have lived if it had a C-section.
I don't know what the evidence is going to come out to be.
I'm talking about, that's your purpose for asking that.
That was the purpose for me asking the question.
Sometimes I give advice to lawyers, but I won't here in this case. Sorry,
Thank
we'll
you.
be in a lunch.